Nice. So I'll start. I will share my screen, and then we can probably start. We are almost 10:05. So can you see my screen?
Yes, yes.
Excellent. Okay, so we have 30 people. I think we can get started, and I will call for the comments as well, and we can start and have the discussion about this case. So it's not a fancy case, not about anything too fancy. It's more that my idea with this particular case was to get some feedback and some input from you guys, not only in terms of management of the trauma patient, but also as some insights regarding quality of care and maybe something about the organization and non-technical management of this case. So that's why I brought this up to you guys today. So the case to illustrate this discussion is a 31-year-old male. He was involved in a motorcycle collision against a fixed structure. We don't have enough details about the crash exactly, so we don't know how fast he was. We don't know if he got ejected from the vehicle or not. But the guys that managed this patient on the scene, they told us that he had a Glasgow Coma score of 5 and an alcoholic breath. He had lower extremity trauma, and the ambulance that took this patient to the hospital is what we call here in Brazil the basic ambulance. So we don't have physicians on board on this transportation, and they took about 30 minutes to get to the hospital after the injury. And this is the abdominal, like a picture from the abdominal inspection of this patient. And during the first assessment, he had clear airways. He had a facial edema, so there was concern about facial fracture as well. He got the cervical collar. On his ventilation examination, there were normal bilateral breath sounds. His respiratory rate was 21, and he was saturating 100% on bag mask. Also, on the circulation point of view, he had a heart rate of 94. His BP was 145 per 102. He had a normal pelvic exam, and his EFAST was negative. So unfortunately, I don't have the images. They were not recorded in our machine, but we do have this information that the EFAST was negative. And he had a Glasgow of 14 with normal pupils. So really different from what we heard from the pre-hospital personnel. And on the exam, he had a right tibial fracture. It was an exposed fracture with extensive soft tissue injury on the right thigh. So this was the clinical picture of this patient. So we had a stable patient with no obvious signs of bleeding, except for the fracture in his right leg. And this was his arterial blood gas. So he had a hemoglobin of 17. His pH was 7.25, and he had a base deficit of 8.8 and a lactate of 50. So I wrote the normal values on the right side of the values of this lab. So we can see that his base deficit was increased. He had a 8, and the normal value was the maximum of 3, and his lactate was elevated as well, over the 14, which is the normal value for our laboratory. So this is where I'm going to ask for opinions and to start the discussion. But this patient was considered stable during his first assessment, and he went. They got a CT scan from him and in a total body CT scan.
Carlos.
Yes.
Can you make some questions before you present the CT?
Of course.
Oh, okay. So because the patient was motorcycle, is very frequent in Brazil. This kind of injury is the main cause of death on trauma nowadays in Brazil is motorcycle. A lot of young people involved in motorcycle crash. And these are reality in our country, in big cities like São Paulo. And the pre-hospital was like SAMU, who treats the patient in pre-hospital. SAMU or the firefighters who give the assistance for the patients.
Yeah, the information that we had, it was the Cobon, it's the firefighters coming.
Firefighters,
yeah.
The firefighters. So they are from the police. They are trained, not well trained with large experience to treat trauma patients. But the questions about the Glasgow Coma Scale was 5 in the first evaluation, and after was 14, maybe 30 minutes later, 1 hour later, maybe. Okay, the patient received oxygen, the first treatment can improve, but this first assessment was in your hospital at Hospital de Clínicas, the first assessment, correct? Perfect, perfect. And how long it was the trauma until the patient arrived? 30 minutes? How long it was?
Yeah, so the only information that we have is the transport time, actually. So we don't know how long it took to from the injury to having the pre-hospital guys there. So we only have the information about the transport time from the scene to the hospital, which was 30 minutes. Yeah.
Excellent. So it's a good question to discuss because Dr. Antrash and the others who are in this session, maybe they have a good organized trauma system where you have a good communication. This is a problem that we have in Brazil. You don't have a good communication between pre-hospital and the hospital, the trauma center. So information like this one is confusing. 5 to 14, 30 minutes is not frequent situation like this one, but it's what we have until this moment, and we need to improve the communication between the pre-hospital and the hospital. Like you told, the non-technical skill is very important to take care of trauma patients. So, okay, if you want to discuss with other countries where they have more experience in organize the trauma system, it's very important for us to learn about this.
Yes, sure. Let's hear from them. So Dr. Untracht he has his hand raised.
Well, yeah, I just had a couple of questions. So was he wearing a helmet at the time of the accident? Or he didn't come.
We don't have this information written, but it sure seemed like he was wearing a helmet because he had no obvious, at least he had a facial trauma, but he didn't have any signs of cranial, you know what I mean, like skull injuries. Yeah.
But and he didn't come with a helmet though. It wasn't with him. Yeah.
Yeah, he was, at least when he got to the hospital, he wasn't. There was no helmet.
And yes, then Dr. Utash, yes. Usually they use helmets. Usually they use because it's mandatory. The law is mandatory. You use helmets. Sometimes not in the head. It's the forearm because they put the helmet in the forearm. But it's helmets.
Yeah, in America, I don't know if it's required. You know, a lot of people ride fast motorcycles without a helmet. That just seems, I don't know.
Yeah.
Jeez, you know, I don't know whether they're violating the law or that's just not required. But and then was the femur fracture open?
No, he had a tibial open fracture.
I'm sorry, the tibial fracture was open.
Yeah.
Yes.
Yeah, open fracture.
They usually are. Okay. And then when you examined him, his belly wasn't tender or any of that, right? I mean, he really had no. Yeah. But my concern was assuming that that the first Glasgow coma scale result of 5 was accurate. If that and if these are firefighters, they're probably trained to assess the GCS and some vital signs. I assume that he could have had he could have lost consciousness and then regained consciousness. Now he's in his lucent interval. So with that history, I would have included the head in the CT scan to rule out an epidural hematoma that might become manifest. But I think in this case, the 30-minute delay selected out for all the very serious injuries affecting the airway, breathing, and circulation. So,
Yeah.
you know, he's been selected out for that.
Yeah, I'm sorry. I guess I was not clear enough, but he got a whole body CT scan, so we included the head CT. Yeah. So let me see here, Dr. Supa, do you have any comments about that pre-hospital situation? How is it in Thailand?
I think the situation is pretty much the same in Brazil and Thailand. We have some pre-hospital services that are governmental services, but most of the pre-hospital personnel in my country, they are like a foundation, and they work independently. They just scoop the patient into their van or their car, and then they send the patient to the nearest hospital or the hospital that they have made contract with. So if the patient is transported to the hospital by the governmental personnel or the trained personnel, they would be transferred to the proper trauma center according to their severity. But if the patient is transported by the foundation-based pre-hospital, they would be transferred to the nearest hospital, maybe governmental or private. But we have the same problem. And number two, communication is not as good as in the US. In the US, you always know when the patient will come, you know the ETA, you know the mean of transportation, you know the signs and symptoms of the patient. But in my country, if we're lucky, sometimes they call in minutes before they arrive, something like that. And the information is not so medical. It's not so formal. So I think we have the same problem. Thank you.
Yeah, I feel that sometimes the information is not that accurate, and I think that the way that it works here in São Paulo is very similar to how it works in Campinas, where Gustavo Fraga works. So I think that we have similar realities here regarding the pre-hospital setting. Yeah. Okay. So I'll just proceed here to the CT scan, and we have I will show first the thoracic CT scan. You will see that he didn't have any, I mean, there were no critical injuries, like parenchymal injuries, actually, because he had a small pneumothorax, but really small. He wasn't even seen, or he had no clinical repercussion. And he had some rib fractures in the left side, actually. So had multiple rib fractures, but with minimal dislocation of the cortical. So we didn't, I mean, it was a thoracic trauma, but nothing really scary here in the thoracic CT scan. And I'm going to show you now the abdominal CT scan, and then I'll show what was the discussion about the injuries. But I'll just roll this CT scan, and I'll open the microphone for you guys to comment on the findings, and are there any injuries that are worrisome? What are you seeing here in the CT scan? And then I will just go ahead and say what the radiology team said about this. Dr. Kasim, are you available? Are you around to comment the CT scan as well?
Good morning. Yes, I'm available.
Nice.
But from distance, this CT scan is not really clear enough to give you a detailed description of what I'm seeing. It will be essentially, I'm just glancing through it, and I see a full bladder there. And if you run it through, I see the liver. Underneath the liver, there seems to be some fluid there. And the right kidney or the left kidney seems to be looking abnormal. And I don't see any obvious free air in the peritoneal cavity. And I'm looking for the spleen, and I'm not getting a good picture. Oh yes, there is some problem with the spleen as well.
Right.
So just from quick glance, the spleen and the kidney on the same side looks abnormal to me.
Excellent. Yeah, that was the first impression as well. Dr. Untracht, do you want to comment anything else that you saw?
Yeah, no, I agree with that. It looks like a fracture of the left ninth rib, and then a hematoma in the muscle, and then the adjacent contusion. It looks like maybe grade 4, 3 or 4 laceration of the spleen, and then filling defects, perfusion defects in the left kidney adjacent. So it looks like the impact was mostly on the left side, and he has a contained hematoma of the spleen. I agree with Dr. Kessel about that.
Yeah, perfect. Dr. Gustavo Fraga. I'm
Small
sorry.
pneumothorax on the left.
I'm sorry, Dr.
Yeah,
Untracht?
small pneumothorax on the left with the side.
Yeah. Yeah,
As you said, small pneumothorax. So all the impact on the left side.
Mm-hmm. Yeah, it sure looked like it. Yeah. Dr. Gustavo Fraga, do you want to comment anything in the CT scan?
So I can see the splenic injury in the spleen. I don't know if there's a blush. And can you come back to the pancreas? I want to look in the pancreas because, yes, go. Yes, you need to look all phases of the CT in this pancreas. And the kidney, there's some alteration, the perfusion of the kidney, the left kidney. But I cannot see anything in the renal artery on the left. But the perfusion is not good. You need to look at the other phase. There is free fluid on the pelvis. Small amounts of free fluid in the pelvis. Yes.
Yeah, excellent.
So it's important. You have a splenic injury, but look at the mesenteric. If you have associated mesenteric injury in the small bowel, sometimes you have associated because of the mechanism of trauma. And it's very important. I'm sure you analyze very well. Look at the thoracic aorta because of deceleration. It's very important, the thoracic aorta in this case.
Yeah, we didn't find anything in the aorta, so that part was clear. So Dr. Supa, do you want to comment anything different from them, or should I move?
You can move. I have no further comments.
Perfect, thanks. So that was very, very interesting because this CT scan was read by the surgeons that were on call, and they discussed these images with the radiology guys, and they saw the rib fractures, they saw a grade 3 splenic injury with a small hemoperitoneum in the left upper quadrant and also in the pelvis, as you noticed it as well. And there was a left subdural hematoma, really, really small, really difficult to see in the CT scan actually. And as we commented, the thoracic findings as well, and they were the same that as discussed with the radiology team. So this was actually what the surgeons on call had about the CT scan, every information that they could gather. I wasn't involved directly in this scenario, unfortunately, but what they told me and they passed it on was everything that they discussed was actually these cases. So I wanted to open a quick discussion with you about how would you manage this patient, looking at the clinical scenario, the laboratory exams, and also about the CT scan. What would you do? Would you do a non-operative management? Would you do a diagnostic laparoscopy or an exploratory laparotomy? This, I mean, at this moment, the patient was stable and with no signs of peritonitis. He had abdominal pain, but no peritonitis. So let's start with Dr. Supa. Do you want to comment this part?
Yes, and how bad was his right leg? Any vascular injury?
Yeah, so he had an open fracture, and the orthopedic guys were discussing the operative management. He would go to the OR for repair of the right leg.
But the vessel is okay, right?
Oh yeah. He's well perfused. There's no signs of ongoing bleeding.
I think in this case he's alert and he is observable. So I think I'll let the ortho guy fix the right leg, and then I will do the non-operative management on him. I will do the serial physical examination, serial hematocrit, and check for signs of peritonitis. And if I'm in doubt, I will operate on the patient later. But I think if you are a good laparoscopist, choice B is okay for me too. You can do that while you're already in the OR with the ortho guy. But for me, I prefer non-operative management in this patient. Thank you.
Perfect. Dr. Untracht, what is your opinion? I don't know if Dr. Untracht is still here. Dr. Gustavo Fraga, what are your thoughts?
I think you need to discuss this CT with the radiologist, because you need to look in the spleen if there's a blush, because you showed the arterial phase. I suspect a blush in the spleen. So it's very important to look at the venous phase in the CT about the splenic injury. It's important to try to identify if you have a left renal kidney artery on the left, if there is an injury, because the perfusion was different left and the right. And how was the Glasgow Coma scale of this patient? Still 14?
Yeah, so in this moment it was still 14. And about the CT scan, the radiologist team did not see any signs of blush in the spleen. And also they could not find any renal artery injuries.
Perfect. So I think this patient is a candidate for non-operative treatment. You need to have put in the ICU. You can do this in the ICU, and just to follow this patient. Just to remember, the arterial blood gas of the patient on admission was not normal, because he has the base depth was altered and the lactate was higher than the normal. So you need to take a very close the follow-up of this patient at ICU. But I think it's a candidate for non-operative treatment. And the orthopedic is probably we operate the open fracture. So you lose the contact with the patient, where the patient, the OR with the orthopedic team, the surgeon needs to follow this patient very close.
Perfect. Thanks. Dr. Kassim, any additional comments?
I think the single most important thing so far is what Dr. Fraga is saying, that in two specialty injury, the captain is still the general surgeon, and he needs to be in charge of this case. Once you get orthopedics involved, they try to take over, and don't let them do that, because the important aspect of this case is abdominal trauma, not the leg, as we already know that he does not have any vascular problem in the leg. Yes, it should be treated, but the abdominal trauma take precedence, because that's where he could hemorrhage and die. And he will not die from a tibial injury immediately.
Yeah.
So I think he's got, let's look at this a little different. You're suspicious of abdominal trauma, and you're suspicious of two organ injury. One is the spleen, the other one is the kidney. Even if the renal artery is not involved, there is a parenchymal injury to the left kidney, and there is an obvious grade 3 injury, or maybe even grade 4 injury to the spleen. And did you say he's a young person? He's in his 45, right?
31.
He's probably well compensated, and he's got fracture to the right leg. So if you add two organs plus leg, he technically should be hypovolemic, but he's not, and he's tachycardic, and he's going to crash. And you allow the orthopedics to work on it, and then you are going into a code blue trauma, and the patient is going to be crashing in the operating room or on the table. Bad scene. You want to avoid that.
Yeah.
So what I would have done is I would have put all my concentration on the abdominal trauma and dress the tibial injury as much as I can, and for later treatment. And I want to know if I was going to institute non-operative treatment, or if I was going to do a direct treatment. Laparoscopy would be a very bad idea, in my opinion, unless you're called Dr. Collet. He can do that, and he is very good at it. But in my hands, I would not do that. And because I already know he's got hemoperineum. And the question is, should I go and stop the bleed, or should I watch the patient to bleed even more? And in my train of thought, I think I would like to play a surgeon. Take the patient to the operating room, stop the bleed. Thank you.
Yes, thank you. So very interesting. That's what I wanted to have the different point of views, because we have a relatively stable patient with the splenic injury, but there are a lot of other injuries as well, and so there's room for considering also the interventional procedures and also maybe the non-operative management. Dr. Untracht.
I don't know if you got to all the others yet. My screen froze, so I had to log back in. So I don't know how much I missed, but it cut off just before you started asking for comments. So did Dr. Fraga get to go?
Yeah, he just spoke.
Okay. So yeah, so you said the patient's basically stable. The vital signs, he was not tachycardic when he came in, and then he was hypertensive, actually, and he's still hypertensive. So
yeah. I'm sorry, but we don't have the exact information. We only have the information that he remained stable. We don't have the actual numbers in this scenario now.
Okay, because you weren't there. Okay, then this is a case, sounds like one that Dr. Fraga would present. And stable patient who had had good vital signs when he came in. If he, if I were at the bedside and he remained non-tachycardic and the blood pressure was stable and his Glasgow Coma scale of 14, with the full CT scan that you have, then I think you have options. One, you could still go to the OR and take out the spleen. He's 31, and assess the kidney. You could do all of that, and then deal with the open tibial fracture. Or the other option is to use classical non-operative management for a patient who's stable. Basically, he has one organ injury, and the spleen, and some contusions of the kidney, and then he was a little bit acidotic and he had a high lactate level. I would, if he didn't go to the OR, I'd give him some fluids, watch him, and then the third option is what I think Dr. Fraga might do, is to take him to angio, or look for a blush, the CT scan. If there's a blush, take him to angio, embolize the spleen, and then observe his urine output, observe the function of the kidney. You can assess that with ultrasound, and take that approach. And I think that's also, in the right hands. I think in Sao Paulo and Campinas, that would be, I'm sure that would be something that Dr. Fraga would do. He's presented more worse cases than this, treated successfully with interventional radiology, patients who are hypotensive and in a much worse condition successfully. So I think that's also an option.
Yeah, interesting. So he didn't have any blush in the arterial phase, but would you consider doing a angiography with embolization even without the arterial phase?
No, not if there's no blush, because that's okay. This is a case where in this situation it's acceptable to carry out non-operative management.
Thank you. So we did the same thing, but we didn't operate. We tried a non-operative management, and after the CT scan, he had a drop of his blood pressure, and because of that, and also the arterial blood gas, they gave a total of 1,000 cc's of ringer lactate, and just 1 unit of blood in all this scenario. So that's another thing that we can discuss further because of the case. And I don't know exactly what happened in this time frame, but the patient was deemed stabilized after the transfusion, after just 1 unit of blood and 1,000 cc's of ringer lactate. And these were the next numbers that we got from the chart review and from the people that were caring for this patient in that time. So I wanted to ask a quick question for you guys about, of course, for the ones who chose a non-operative management. Would this drop in the blood pressure, would this be considered a failed non-operative management for you? And would you do anything different from the initial plan, or would you stick to the plan and okay, he's transfused, he's now stable again, and we're just moving on with this scenario? What would you say, Dr. Untracht?
Well, what about his lactate and pH?
So we don't have a sequential analysis of the blood gas, unfortunately.
And
they didn't get
urine
it.
Urine output's okay?
Yeah, it's okay.
Yeah. If he stabilized with that, and that's all he needed for the time he's been there. This is what, 2 hours after 2 hours in the hospital?
I think that I would say that maybe a little bit less, maybe an hour after he got to the hospital.
I think it's still okay to observe, and then if he becomes unstable again, if he drops his pressure again, then he just needs to be fully reevaluated. He may be bleeding more, starting to bleed, in which case, I might consider taking him to angio, because if he's going to bleed, it'll be from the spleen, not from the kidney. And that would be my plan. Is that, since he didn't go to angio at first, if he gets hypotensive and tachycardic again, and he responds to fluid, then I would go straight to angio. If he gets unstable, doesn't respond to more blood, then you'd have to probably go straight to the operating room.
Great, thank you.
In this case, I would do it open. I wouldn't do a laparoscopic laparoscopy for ruptured spleen.
Perfect. Yeah, Dr. Cassin, he already wanted to operate. So I'll just ask Dr. Gustavo Fraga if he would change his plan based on this blood pressure drop, or would he continue the non-operative plan?
Yes, probably this patient, he needs more blood, only 1 unit. Usually you can give until 4 units in the first 24 hours if the patient is like this one, until 4 units. More than this, you prefer to go to laparotomy. Maybe not laparoscopy, go direct to laparotomy, to splenectomy, because the patient is bleeding. But in this moment, I think you should keep the non-operative treatment at ICU. He was operated in the tibial fracture.
Not yet. He was going to.
Was going to, and was not bleeding in the extremity. No bleeding.
Yeah, no ongoing bleeding.
Okay. Yes, because you lose the contact with the patient when he go to the orthopedic team operate, because the anesthetists usually they give a lot of crystalloids and they don't give so much blood. They prefer to give crystalloids. Our anesthetists in Brazil, Carlos, they don't like blood, like the trauma surgeons like blood. They prefer to give crystalloids. So this is a critical situation because the prognosis of the patients can go worse with a lot of crystalloids. But I think it's safe keep the non-operative treatment at this moment with the trauma surgeon following the patients.
Perfect. Awesome. So I'll just move a little bit in the interest of time, and I'll get the other people to comment as well. So he was, unfortunately, he was transferred to the Orthopedic Institute for this treatment. This was based on a logistical decision, like more in the administrative part of the decision than the medical, actually, because the Orthopedic Institute is outside of our General Surgery and Trauma Institute. So it's not something that we like to do it, but in this case specifically, it was done. So he underwent surgery, surgical debridement, external fixation, suture of the soft tissue injuries, and he was stable during the procedure. What we have in this scenario now is it's that we got the final report of the CT scan, which was now read by an attending, and which was not the case when he got to the hospital. The CT scan was read by the residents, and the final CT scan report showed a mesenteric straining at the level of the jejunum and a rectosigmoid junction, and both had active contrast extravasation in the venous phase, not in the arterial phase, but in the venous phase. And the jejunal wall was thickened and also had a contrast enhancement. This was the information that we got after after the patient was operated on by the orthopedic surgeons, was 1 day after the initial presentation. But the patient remained stable with no vasoactive drugs. He was extubated, and he had mild abdominal pain, not something that was too shocking for the attendings that was taking care of this patient. And upon the physical exam, he had diffuse mild abdominal pain upon palpation with no signs of peritonitis. So what I wanted to ask you guys, and I wanted to show you what the CT scan, what was this contrast extravasation. So it's very, they didn't see in the first time that they look at the CT scan. So you'll see this in the jejunal. It's right here. It's like a very small, and I put this in a picture on the right side. So it's a very, very small blush that was interpreted afterwards. You can see that there was bowel wall thickening as well, close to this contrast extravasation. And you will see at the end of the CT scan in the rectosigmoid junction, there's also a little bit of contrast extravasation, and you will see this right here. So this is the area that they saw a mesenteric blunting with also the contrast extravasation, and I put this picture over here. So as I said, this was read afterwards, and they didn't have this information beforehand. And another finding that was not commented on beforehand was that he had a small lower back hernia over here at the posterolateral aspects on the right side of this patient. So these were new information, and the patient remained stable, as I said, with mild abdominal pain. This was his arterial blood gas along the days that he was with us in the hospital. So this first one is the from the admission, the arterial blood gas from the admission, the same that I showed you before. And these other exams were under his length of stay in the hospital, so the next 2 days. And you can see that the arterial blood gas is improving as well, and the patient is stable during this part. So I wanted to ask you quickly, what would this information about the mesenteric straining and the contrast extravasation close to the colon and close to the jejunum, would this change your management? Would this make you consider stop the non-operative management and do something different? Maybe another CT scan, a control CT scan, maybe diagnostic laparoscopy now, maybe exploratory laparotomy. So Dr. Gustavo Fraga, what would you do? Would you do something different?
Yeah, if you have a suspicion that something is not going well, something wrong, usually repeat the CT. You repeat the CT and thinking about stop non-operative treatments, because 3 days later, correct? 3 days later.
Yeah, it was the second day of admission.
Admission. So repeat the CT, but if the surgeon has some feelings about the evolution of the patient, want to go direct to the OR, is a good option too. It's a good solution. But usually here is on the University Hospital, you repeat the CT.
Excellent. Dr. Untrak, do you agree?
Yes, I do. In this case, I would repeat the CT scan anyway, but I would also watch the lab results. If he's if he's developing leukocytosis, if the lactate level doesn't resolve completely to normal, I'd be concerned. If he had more abdominal tenderness, then I would, as Dr. Fraga said, I would probably err more on the side of being aggressive and taking him to the OR for laparotomy. But I would repeat the CT scan regardless. Excellent.
Yeah. So his white blood count on the admission was 21,000, and on this particular time it was 17,000. And his blood gas analysis was better, but he still had the abdominal pain in this scenario. So again, I'm going to ask Dr. Kassim. Dr. Kassim wanted to operate this patient beforehand, so I think that he would still keep his opinion. Is that right, Dr. Kassim?
Absolutely.
Great, thanks. I'll call you.
Listen to me. I was trained. Well, I was not trained, but I was intimately involved by Dr. Trunke, who was a professor of surgery at Portland University. And he said there are more patients who have died from non-operative treatment than the operative treatment of splenic injury. And that left a mark on my brain. And this case is a very good case to remind me that I need to be a surgeon. I don't really subscribe to the idea the patient needs 3 CT scans to diagnose something that is quite obvious, that there's something wrong in the abdomen and he is not behaving like a normal patient. This is a variant, and I will go and examine him. And on the strength of my examination, I will make a decision. And in this case, in this particular case, what my decision would be that he's got abdominal tenderness and he needs to go to the operating room.
Excellent. Very nice. Thank you. Yeah, so the team decided to do another CT scan. So the second repeat CT scan, the second one. The labs were, as I said, improving, but he still had some abdominal pain. And this is what they found in the CT scan. So you can see this is going to the abdomen, and now he has pneumoperitoneum on the right side here over the liver.
Yeah.
There's his spleen injury here. The same thing. There are no blushes, no contrast extravasations, but the contrast extravasations from the small bowel and from the colon, they disappeared. But obviously something was wrong. I mean, you see the pneumoperitoneum, you see more fluid in the belly. So gathering all the information retrospectively, they thought maybe we had a bowel missed injury in this scenario, and that's what we are going to discuss afterwards. So because of the interest of time, I'm going to move forward and make sure I get more comments from you about the management. So while they get the CT scan, they are taking the patient to the OR. They are signing the papers, and the patient starts to deteriorate. He starts to complain about increased abdominal pain, tachycardia, and his SBP is dropping. So this is while he's going to the operating room, and this is what they found. So there was some fluid in the abdominal cavity. It was like not active blood, but there was a blood coming from maybe from the splenic injury. So this was a small bowel injury that they found upon laparotomy, and you can see on the right side that you have a hole in the mesentery of the colon, just in the rectosigmoid junction. So we have a mesenteric injury which is big enough in close to the colon, and not a mesenteric tear, but you have a small bowel, maybe a blowout injury, as we can see in this picture. So what I wanted to ask you is, seeing these injuries, what would you do in this situation? And you can comment any ideas that you have. I listed 3 of them here, but you are free to comment anything that you would do differently. So, Dr. Gustavo Fraga, what would you do in this case, in this scenario?
In the small bowel, I think you can perform a suture, debridement of the wall and suture. And the colon, I think it's no ischemia in the colon, only the mesenteric hole, but no ischemia of the colon.
Yeah, I'm sorry, the picture was not that good, but there was necrosis of a segment of the bowel.
So you need to resection and probably primary anastomosis, because 48 hours is a little dangerous. Depends of the contamination of the cavity, if you have peritonitis, but probably I do anastomosis, primary anastomosis. And if the small bowel is so a lot of edema, very difficult to close the abdomen, you can make the resection and do the anastomosis like damage control in the next surgery. I think it's a good option in this situation too.
Perfect, thanks. Dr. Kassim, would you do anything different?
I would resect the small bowel and do a primary anastomosis, and I would exteriorize descending colon colostomy and staple the distal end. I would not do an anastomosis to that colon at this moment.
Great, thank you. Dr. Untracht, any different ideas?
Well, for the small bowel, it looks like it's a blowout, not due to devascularization. So probably just a transverse repair of the perforation would work in this case, but it's not. It's still okay to do a resection and anastomosis, depending on how it looked. But on the picture, it looked like just simple suturing would be okay, like you would do with any perforation. The colon, I couldn't see in the picture how much was, how big the ischemic area was, and if the colon wall is still intact, and if it's a limited area, you can imbricate it, or if it's in the mid-sigmoid colon on the antimesenteric surface, you can exteriorize it, and then wait for the wound to demarcate and deal with it later. I probably wouldn't do a primary resection and an anastomosis unless it looked, everything else looked fine. It depends on how it looks right at the time of the operation.
Yeah, great, thank you, Dr. Supa. Any other approaches?
For small bowel, I agree with resection and anastomosis. For colon, it depends on the patient's condition and the contamination at that moment. If the patient remains stable and you could obtain a good tissue after debridement or resection of the colon, and no gross contamination, no bad contamination in the abdomen, I would join the bowel together. I think it's okay to do primary anastomosis for colonic injury that the patient is stable and no bad contamination in the abdomen. Thank you.
Great, thank you. Yeah, a lot of different opinions, very, very interesting. So the team that was taking care of this patient, there was no gross contamination. I mean, not a lot of contamination in the cavity, but the patient was not doing so well. He needed vasoactive drugs, and he was not deemed so stable. So the team decided to do a resection and a primary anastomosis of the small bowel, and the resection and colostomy at the colon. So on the left, there's the small bowel and the injury that they found, the blowout injury, and on the right side, the segment with necrosis in the colon. So that was their decision intraoperative decision. And a quick question for you guys. Would you take the spleen out, or would you leave it there? Because there was no bleeding coming from the spleen. But as Dr. Kasim reminded us, I mean, you have the belly open. Would you leave the spleen, or would you take it out? Dr. Untrak, what would you do in this scenario?
Yeah, it's a tough call. If it really isn't bleeding and he didn't have a transfusion requirement, I would be inclined to leave it alone, because then, if he does start to bleed, you can always take him to this radiology, embolize it, and then if you get too aggressive, you take out the spleen, he may get a subphrenic abscess, and then it's a tough call either way. But in this case, for someone that's not actively bleeding, I would leave it alone at this point. Especially since you said he needed some pressors, and it wasn't due to bleeding and maybe from sepsis. So I would leave it.
Okay. Dr. Gustavo Fraga, would you do anything different?
No, during the laparotomy, during the colon mobilization, if you have some bleeding coming from the spleen, I will take out this spleen. Splenectomy, I think, is safer for the patient at this moment. And I think it was a good option due to the bowel resection with anastomosis. And the colostomy, there's a lot of discussion about colostomy. But this patient was operated more than 40 hours later after the trauma. I think it's safer for the patient to have a colostomy than to try to perform a primary repair. Depends on the local situation of the cavity. But excellent case. And this diploma about communication with the radiologist, because if you have a radiologist in the hospital on call, you need to have very quick the report of the CT. So you do maybe this laparotomy before.
Yeah.
Because you don't know this information about the small bowel. Excellent case. Congratulations.
Yeah. Thank you. Dr. Super, would you do anything different? Would you take the spleen out or would you leave it?
I'll leave it. I wouldn't take the spleen out.
Interesting. Nice. I won't ask Dr. Kassim because I'm embarrassed because he's going to say that he would take this out promptly.
You're wrong. I
Oh,
would
really?
not do that. Yes, because you know when you are doing with multiple organ injury, if an organ like spleen is not bleeding, play chicken, don't play turkey. Just leave it alone.
Yeah.
Especially on a patient who is on vasopressors. You know, if it is
Interesting.
not bleeding, if you know, very simple idea. If it is not broken, don't go and break it.
Yeah. Nice, interesting. Thank you very much. So I spoke to the surgeon who was taking care of this patient, and he saw the spleen, and he thought it was too oh, he's badly injured, so I'm taking it out. So the final report of the operative procedure was that they did all that I showed you. They did this splenectomy as well. They thought it would be safer to get it out, and they left some drains in the splenic area to make sure that, I mean, there might be some injury to the pancreas or anything regarding this situation. So I'm just going to run quickly through the post-operative course. So he had fever on the 5th day and on the 17th day. He got new CT scans with no intra-abdominal collections, but his drain output was showing high amylase in the drain. So probably he had really a pancreatic fistula. We don't know it from the trauma, from the splenectomy. Ortho, they did a definitive repair on post-operative day 8. Then he had a new fever. They thought about central line associated infection. They also thought about maybe something in the belly. They performed another CT scan with renal vein thrombosis, no collections. The patient was managed non-operatively afterwards, and he was discharged on post-operative day 25. He's now on our clinic. He's doing well, but with this, he's now waiting for bowel reconstruction, bowel colostomy takedown. So I just wanted to show you an interesting study about this situation, because one of the interesting parts of this case was the presence of the bowel wall thickening and also the presence of contrast extravasation in small bowel and the colon that were not readily identified in the first assessment of this patient. So I brought you guys an interesting study from Joe Honkoff and his colleagues from Houston about the BEEPS score. So I don't know if everyone is familiarized with the BEEPS score, but it's something that they developed to help us identify patients that should undergo surgery because of bowel injury. So they say that it's a rare situation, 1.1% in the literature, according to Fakri et al. So the problem is the balance that you have to have between missed injury and doing a non-therapeutic procedure. And they talk about the complications of this, and can surgical intervention be predicted using any form of scoring system? And that's what they analyzed in this scenario. So they had more than 18,000 patients, but they selected 110 for this study, and the BEEP score was developed according to a ROC curve, which multivariate analysis of these patients, showing which one had injury in the bowel that necessitated a surgical repair. So this is what they found, and they created this grading scale for mesenteric injuries, and they say that the BEEP score would be 0, 1, 2, or 3, based on the number of factors that the patient has. So it would be white blood count over 17,000 on admission, abdominal tenderness, and a grade 4 injury, because they say that the grade 5 is definitive of bowel injury and they should be operated. But if you have the combination of these scores, you could use it to predict the need for surgery. And they show that if you have a BEEPS score of 2 or 3, you would end up with a sensitivity of 85% and a non-negative predictive value of almost 90% for the need for surgical repair of the bowel. And they end this study by saying that when you have solid organ injury with concomitant bowel injury, this can be very misleading. And I think that's one of the reasons that we had this problem in this case. And they say that this probably is the reason why they have a high rate of solid organ injury in patients who were operated delayed in this study that they showed us. And also they say that if they had the BIP score beforehand and they applied to this 110 people, they would have a difference from 25% to 10% reduction in delayed operations, because they could use this score to help them decide if they would operate these patients early or later on. So I thank you very much for your attention and for all the comments. I'm going to open the discussion for you guys to make final comments and take home messages. And I really appreciate everyone that participated. So Dr. Gustavo Fraga, do you have any comments for any final comments, take home messages?
Take home message: teamwork. You need to work together with the radiologists and other specialists like orthopedics, neuro, the trauma surgeon. He coordinates the team, but you need to have all the team at the same level, offering the best for the patients. If you have the radiologist, the report before with this presentation, this paper, very interesting. So I ask you to share by WhatsApp this paper. Maybe you have it. Excellent. And I think this is a take-home message. Sometimes it's difficult because we like trauma, we like to stay on call, discuss cases, and the other specialists, they are not they don't have the same love, patient that we have to take care of the trauma patients. Excellent case. Learned a lot with the students. Congratulations.
Yeah, thank you. Yeah. And I feel that there are a lot of things from the quality perspective to discuss in this case, because we had some major problems, not only for example, the radiology report that could be better in the admission time, but also this decision to transport the patient outside our institution maybe had a negative impact in the outcome of this patient as well. Dr. Untracht, do you have any final comments or take-home messages?
No, excellent case. I think so. I gather if you gotten the first reading, if it was a correct reading, and you knew about the bowel wall thickening, you would have operated that night, the first night. Well, I guess that's a reasonable point. So it's a matter of the reading given by the radiologist. But otherwise, it's the Swiss cheese, that Swiss cheese model. So the radiologist didn't give a correct reading in a timely manner, but you still watched the patient, and he got more tender, and and you would have managed the patient based on those criteria, and you would have, and as you did, and you still got a good outcome. So it's a matter of balancing all the different aspects and realizing that anyone can make a mistake, but as long as the mistakes are not they don't line up and allow a bad problem to work its way all the way through the system. But fascinating case, excellent case, and learned a lot.
Yeah, we thought the same thing. So it's more like what can we do to improve this? The outcome was not bad. I mean, the patient is alive, he's well, he's with us in the clinic. But how can we improve the quality of care that we gave him, right? And as you asked, so I went to look for the white blood count of this patient upon admission. So it was 21,000. So his BIP score actually was 3. So he had the maximum score. So looking retrospectively, probably we will, if I was also having this information correctly from the CT scan report, I think I would do a laparoscopy probably, because I would be concerned of the bowel injury. But as I said, it's always looking retrospectively, and that's why I actually try to hide this information beforehand for you guys, because I wanted to have this discussion just as they did, so exactly the same as they did with the information that they had upon that time. So thank you very much, Dr. Untracht. Dr. Kassim, do you have any final comments or take-home messages?
The take-home messages are three. Number one, you need to have a better trauma system, okay? Because if you keep doing this again and again and expect a different result, that is called stupidity. And a country like Brazil, so advanced in South America, you need to start thinking about having a trauma system for the whole country. It will take probably a decade to get it going, but if you don't start, you will never get there. And that's what happened in United States. First, they started it in Maryland, then they moved on. Seattle took 10 years, and Oregon took 15 years to get the proper trauma system. But I think some leaders in Brazil should talk to your president and get this going. Number two, it is a bad idea to transfer a trauma patient to some other institution where they will be doing something different that one hospital is not doing. Once you do that, you lose control of the patient. Number three, that you need to have proper radiologists on call to be able to interpret what they are seeing, because residents are not good enough to interpret nighttime CT scan or off-hour CT scan. And all those are a critical issue that need to be re-evaluated. This patient survived because your surgeons are good surgeons. You have very good surgeons. You just have a very poor system.
Yeah, exactly. So that was the reason to bring this up, because it's more of a quality control perspective, right, as well, to make sure that we are trying to do this better.
I can guarantee you we will revisit this 5 years from now. There will be another case like this.
Yeah. We need to try to make sure this doesn't happen, but I don't know. Dr. Supa, any final comments and take-home messages?
Thank you, Carlos, for presenting this interesting case and very educational. What I learned from this case is that we should have a low threshold to operate on the patient who undergo non-operative management for something in the abdomen, because the patient may have bleeding later, may have a peritonitis later, and the outcome can be very bad if you delay treatment of bleeding or infection in the abdomen. My professor taught me that when you do the non-operative management in the trauma patient, the patient has to be better every day. Every time you see the patient, he has to be better. If he deviates from a good recovery, whatsoever reason, we should have low threshold and operate on the patient. But I learned that from your case too. Thank you very much, Carlos, and very good management.
Yeah, great. Thank you, everyone. So Dr. Gustavo asked for the article. I just put in the chat the link for the article, and I'll send in WhatsApp as well for you, Dr. Fraga. So everyone, thank you very much. I hope to see you again in the next meeting. So next week we're going to have the PDS and AAST meeting. So make sure to save the date and save the schedule for this discussion. It is going to be really interesting, and the case is going to be presented by Dr. Gustavo Parreira, which is a Brazilian trauma surgeon as well. So I think we're going to have a really interesting discussion. That's awesome. Thank you very much, guys. Thank you for being here, and I learned a lot from you today as well. Thank you.
Congratulations. Excellent case. Congratulations.